So
Yep, this is the
thanks, Pete. Thank you to Team OrthoHub. Okay, so thanks for asking me tonight to come and speak about fragility fractures in relating to the acetabulum. As Pete mentioned, I'm a fellow consultant at the Royal London Hospital, and I've been Pete's colleague for the last 10 years and working in setting up our pelvic unit. Fragility fractures in the area of the acetabulum. So what we're talking about is fractures that are affecting the elderly population. So unlike the high energy injuries, this is really, we're talking about falls from a standing height, and the resulting injury patterns that kind of follow on from that, and the fact that unlike the high energy fractures, where the fractures, if you like, are quite clean, in the osteoporotic bone, we're seeing a different pattern of fracture. And unlike the clean breaks, we're seeing deformity around the joint, and deformity which includes the articular surface. And this is very difficult to deal with. And this is what sets this form of fracture apart from the high energy, better quality fractures that we see in younger patients. And so we see this difficult combination of femoral head damage, distorted anatomy with the femoral head pulled in through the pelvis, and the impaction to the cancellous bone around the joint. And it was Anglin about 20 odd years ago who described the gull sign. And the gull sign is quite a classic finding in the osteoporotic fracture. And what it represents is the femoral head being pulled medially, and it's the deformity that involves the anterior column. And what Anglin described it as is this harbinger of failure and doom. So in his series, this universally resulted in a very poor outcome. And this isn't something you see in the younger patients. So Mata, in documenting his highly impressive case series, he did a case series where he was able to compare his practice, if you like, in two different time frames. And what he noticed that over a period of, I think it was about 24 years or so, that the first decade, there was many more high energy fractures, a much lower propensity to osteoporotic fractures, but this increased dramatically as time passed. And this was a paper that he published, I think 15 years ago or so. So the propensity for osteoporotic fractures is increasing. That pattern is continuing. We're seeing the characterizations are different. We're seeing a much higher involvement in the quadrilateral plate, and this concept of medialization of the hip, impaction into the dome, which is a result of failure in the anterior column, much higher instance of impaction throughout. And all of this is associated with a really poor outcome if what we're talking about is just fixing these fractures. So what are the current management strategies in treating osteoporotic fractures? Well, much like LC1s, it's pretty disparate. There's many strategies. Evidence is in its infancy, as Kelly was describing earlier, and that's absolutely the same for elderly acetabular fractures. It's hugely variant on where you are, what surgeon's treating you, and what resources that surgeon has available to him and his experience. What about conservative management? So, I mean, conservative management is always an option. The reality in conservative management, when we're talking about displaced fractures, so I think conservative management in an entirely undisplaced fracture in a compliant patient may be a reasonable option, but conservative management in a patient that we are anticipating or hoping for a good outcome is not realistic and tend to do very badly. So I think it's really reserved for a non-ambulant patient who is really not fit enough for any surgical intervention. So classically, your severely demented patient. Conservative management is not without its hazards. So this was a patient that had a bilateral acetabular fractures. The right side was managed conservatively, and this becomes very, very difficult to deal with. This woman did have multiple comorbidities. She was a kidney transplant patient, diabetic. However, she was ambulant. She was independently mobile before her fall, and to resolve this becomes a very, very complex surgery, and the patient has had a period of immobility, and this serial medial migration results in a very big acetabular defect, but it also begins to affect the femur. The greater trochanter is knocked off, and therefore you get a significant compromise in abductor function if you're going to then consider a reconstructive procedure. Which in this case we did, and had a reasonable outcome and got her back to being mobile. But this would have been much, much easier if this had been managed more acutely. What about percutaneous fixation? I think this is a really reasonable option in a small select group of patients. I think is a really nice way of managing pain in the undisplaced fracture and permitting early mobility. It also has a role in the patient that is perhaps too sick for a bigger procedure and is not very mobile. So the example that I have of this is a patient who is just really not fit for a haircut. She was obese, and she had advanced COPD. She was on home oxygen. The problem was that this injury pattern would not permit her to sit up, and so even going bed to chair and for a simple transfer was a challenge for her. We elected to treat this with a percutaneous technique. We use the star frame to distract the femoral head away from the acetabulum, which is the deforming force. And it is possible using a percutaneous technique to improve the overall alignment and to provide some form of stability. The reality of this is identified already as a pretty poor prognostic injury. So this probably isn't good enough for her to get up and mobilize with or weight bear, but for her that wasn't relevant. And so what it did permit was her to sit out of bed and have a much more congruent and less painful hip. Fixation alone. So we've identified that there's a number of radiographic and CT parameters that indicate it will be very challenging to get an anatomic reduction. I think if it's achievable, then fixation alone is a very, very reasonable treatment strategy, and indeed the preferred treatment strategy when it's achievable. The problem is that in a significant proportion of the acetabular fracture in the elderly population, because of all the deformity that arises around the joint, that is not achievable. So if this is the result you achieve, then fixation alone, I think, is the preferred management strategy. One might say, why don't we fix it and then return with a hip replacement if your fixation subsequently fails? And I think there is clearly a logic to this. A patient that we had, actually, this came to us in 2011, and so this was a time when we hadn't really progressed into acute fix and replace, and so this was really treated along more traditional treatment pathways. So there was already some damage to the chondral surfaces. He came to us a couple of weeks after his injury, and there's medialization, there is incongruence of the hip, there is a femoral head that's likely to be damaged because it's been in contact with an exposed fracture. And so initially post-operative radiographs are actually quite favorable, and this is him only 4 months later. So at 4 months, we've already got quite strong evidence that this has failed. Clinically, he's doing poorly. He's got pain. He's clearly developing degenerative changes in his hip. And so the decision is made that we're going to proceed with a replacement. Now, the problem here is the system that we're working in, and we don't have always direct access to do these cases when they're away from the the urgency of an acute fracture. So from December through to April, 4 months later, the hip has really deteriorated quite dramatically, and we'd still not managed to get this patient to theatre. In May, we managed to get his operation done, and so there's a 6-month period of him really doing extremely badly. So I think there is, I think, a reasonable strategy to do a trial of fixation, but I think it's important to monitor these patients carefully, and it's certainly preferable to access salvage surgery really early, as early as possible, because large delays, I think, significantly make the surgery so much more challenging than it truly needs to be. So the concept of fix and replace has been gaining hugely in popularity. It's something that's been really taken off, I think, over the last 7 or 8 years. We've touched already on some of the parameters that will guide us towards this being a preferred management strategy. So acetabular impaction, femoral head damage, medialization of the femoral head, and significant posterior wall involvement. The evidence on guiding us which way to manage this fracture group is of poor quality. It's essentially multiple series, fairly small case series. What they highlight is that when we're gathering PROMS type data, the patients seem to do better than the fixation group. The procedure is tolerated, so the patients are in fact able to sustain what's pretty extensive surgery. The complication rate is higher than primary arthroplasty, as we'd expect, and probably closer to a revision hip replacement type of scenario. More recent case studies are being produced fairly regularly, and there's more, I guess, further evidence that that it permits earlier mobilization and earlier return to function, and more favorable clinical results. But really, what we don't have is any strong evidence to guide us one way or another. The reoperation rate from fixation alone is very high. So the appeal of fix and replace is that you're doing it in a single sitting, whether it's a staged or in a single sitting is considered to be one episode, if you like. And there's clear benefits to early mobilization. So the technique that we use in our institution has been evolving, and so this is a presentation of where we started with this and some of the principles that we adhered to which delivered fairly consistent results. So our technique has a tendency to do it as a staged procedure, particularly if we're when the anterior column or the medialization through a stop approach is being addressed. I tend to do this through a staged procedure still. The stop approach has been invaluable in being able to access the medial quadrilateral plate and buttress that back fairly minimally invasively, correct the overall anatomy so we're able to address the medialization. The star frame is really useful surgical technique to remove the femoral head as a deforming force. The theory is that we're returning as much skeletal stability to the pelvis and the acetabular zone as possible. So a hip that's clearly going to struggle, huge femoral head defect, significant medialization, a push-pull technique to restore the overall anatomy, achieve a congruent hip again through a stopper approach, a medial buttress plate, which works very, very effectively, a second anterior column plate, followed by the next procedure, which is to fix the posterior column and proceed with a hip replacement. And you can see we're adhering to maximal fixation. So principles in my arthroplasty are about trying to restore the hip center, essentially, put it as close to where is anatomically normal as you can achieve, because we know hips do much better there. We're using revision sort of principles in that we're able to position our components to maximize bone contact, maximal fixation, so multiple screws, and it's a posterior column that I'm utilizing to hang this implant from. And I like to use dual mobility to facilitate the overall stability of the joint afterwards. And I am a big advocate of using modularity in this system, because I think it gives you a lot of power in optimizing the orientation of your cup to the host bone, yet maintaining a good orientation to deliver stability. These are generally an osteoporotic patient group, and so it tends to be used in conjunction with a cemented femoral stem. So it's revision hip components. It's not typically a primary arthroplasty with regards to a choice of implant. So our early case series, this was the first 4 years of doing fix and replace. So this is up to about 2015. And so just to confirm to really ourselves that this was a viable option, and to assess the cohort of patients that we're treating. The majority are falls from standing height, so they fit with the stereotype that we're expecting. An interesting subgroup was the iatrogenic fractures. So these are patients that have come for a primary hip arthroplasty, and there's been a complication intraoperatively, and they've sustained an acetabular fracture and been transferred over to our unit. That cohort has a very, very much higher complication rate. So that's where we tend to see infections, so that was an interesting early finding, and in fact that continues to be a feature that I see in my practice. So we confirmed that this is tolerated. Our 2 deep infections came with iatrogenic fracture subgroup. We had one case where we lost position, and we had one early dislocation which was treated with a closed reduction. Our case of lost position was when we decided not to stick to the principles that we'd outlined. So we went for a very much more minimal fixation option, and as soon as that patient began to mobilize and weight bear, we lost fixation very early, and I revised it to what you can see below, and the patient went on to do absolutely fine. So just to take you through a few case examples. This gentleman has a highly comminuted fracture with medialization, impaction as we've already defined. I've gone for maximal fixation. It was combined with a pelvic ring injury. And we've got him walking in clinic, not comparable to how patient done. This was simply a fixation group. 72-year-old lady with an injury pattern which is predominantly affecting the posterior wall. And so this was done all from the back and as a single stage procedure. And again, the great benefit is this is her 8 weeks post-surgery, and she's walking without any support, pretty balanced gait pattern.
Okay, wait a minute, I'm back on the video, so show me that again. Show me your exercises. Okay, that's great. And then
an 82-year-old fall from a ladder, so a pretty active guy, but with some significant medical history. I just wanted to show you this CT scan. So it's when we see it's affecting both columns, and actually, if I just show you a snapshot of the axial view, you can see that impaction into the posterior column, which is entirely inaccessible through an anterior approach with regards to how one can fix this. So this fracture would expect to do extremely badly, and fix and replace really worked as a very nice option for him. So this is at 4 weeks.
Start to walk. Yeah, you can start doing that. Great.
Final case to share. So another subgroup that that we've come across is the seizure patient group. So the seizure patients that are quite often present with bilateral acetabular fractures. This particular one is perhaps only one of two that I have that's a unilateral injury. They nearly always have, in fact, they universally have impaction. This guy was fairly young and actually functioning fairly well. So despite him being 57 years old, this was treated as a fix and replace for him a staged manner. So it looks like we've got a reasonable reduction, but actually you can see the defect is still lying within the dome. And so I'm expecting that if we do not address this early, it's likely to go on to failure. So that's what we did.
Okay, if you want to walk towards me, that's great.
And a couple of months we got him walking with a near normal gait pattern. So in summary, I'm a strong proponent of acute total hip replacement in association with osteoporotic fractures when we're seeing the indicators of poor prognosis. So dome comminution, femoral head impaction, quad medialization, posterior column and wall displacement, and delayed surgery. Adhering to principles of maximal skeletal stability, restoration of anatomy, beware of the medialization. We want to restore that center of rotation to where it's meant to be. The use of revision components, and together I think this can deliver actually really very good results. So in summary, all options are open for osteoporotic fractures. It's a very disparate group of patients to treat. This is still, I think, a very, very hard decision maker. I think the extremes of presentation are relatively easy. So the active patient is perfect for fix and replace if you have poor prognostic signs on radiographs. If you can get an anatomic reduction, then I think ORIF alone is very reasonable. And conservative or percutaneous fixation, in my view, is for the undisplaced fracture or for patients that are simply not fit enough for more extensive surgery. Thank you very much.
What are you guys doing for these? Because you run like a trauma team and you have your arthroplasty guys as a separate crew. What's the liaison there?
Yeah, so good question. Well, first thing I'll say is I'm obviously very biased by my own training and my own experience, but the evidence for hip survival and percutaneous treatment is similar to the evidence for hip survival and traditional open approaches. So what groups can be adequately treated with that, I think, is a point of some contention. So I still do a lot of percutaneous treatment, especially in older patients with secondary congruence and without significant marginal impaction. We have been probably a little later to the game with fix and replace than some for the reason you said. It's, pulling the group that's largely doing only elective surgery out at the arthroplasty hospital and not kind of getting into the weeds of call and emergency care often. So getting them to buy in has taken some time, but we're in a real uptick with this, like everybody else. So we're treating many hyper elderly patients with significant injuries with cones a year. We did 4 last year. And then traditional fix and replace we're doing more and more of as well. There is a pending RCT in Canada as well called the Gator trial, which we're involved with.
Great. Mez, tell me about cones. Are cones still on the market, or are they... Because I thought there was some problems with the manufacturing of those.
Yeah, so we do a few cones and have done quite a few cones. And so the cone that was our go-to cone to start off with was the Stanmore cone. And this, you had a hydroxyapatite cementless version and a polished stem, which you could cement. And so that is not available as it was last year or the year before. And the reason for that is mainly the CE marking on that. But there are other cones available. So other companies do a modular cementless cone prosthesis with dual mobility bearings, etc. So yeah, there are lots of different types of cone prosthesis available. I think you've got to get your indications right, and I'm glad to hear that, you know, Kelly says that they've done 4, but they're still doing some open reduction internal fixations and replacements as well, because I think there's no comeback after a cone prosthesis. So I think if you're thinking about some patients who are 50, 60, 70, and you're thinking about doing a replacement, an early replacement, then I think a fix and replace is a very good option for those. I think if you've got the 80-year-olds, 85-year-olds, 90-year-olds, they're the ones that would benefit from a cone prosthesis. So a relatively quick operation, one approach, get them weight bearing.
Paul, back to you a second. So you were talking about doing a front and back approach, but of course arthroplasty kit has really come on since then, and now you can do pretty much everything from the back if you want to, with all the revision components. Why bother going from the front when you can do it all from the back? Why do 2 stages when one will do?
So I think that's been the evolution that I kind of mentioned in passing in my talk. So I think when we started off doing this, my thoughts were that we're really wanting to restore as much skeletal stability as possible and put as close to, the focus was all about restoring anatomy as accurately as possible. And so we were pretty conservative to begin with, and we are more and more ambitious, I guess, with what we're doing as a single stage from the back. I still have some reservation about doing some cases entirely from the back. I think when we've got segmental anterior column loss, and a lot of displacement, is asking a lot of your components to do all from the back. When we have the ability to go from the front, that actually we know is quite well tolerated, and restore that anatomy, restore the bone contact, and I think I still have some hesitation for the more complex end of the spectrum. For sure, the simpler end. Small anterior column defects, we're doing them all from the front, all from the back as a single operation.
Great. Mez, is that your experience as well?
Yeah, I agree. So we've been through a whole circle of things. So yes, Tony Ward came back after his fellowship in Pittsburgh and set up the unit with us. And he was with Dana Mears, who used to do them all through the posterior approach and firing an anterior column screw. But, you know, we had slightly different implants than what we have available now. Those patients were managed touch or non-weight bearing for a period of time, and then partial weight bearing for a period of time. And so the demands of the patients have changed, implants have changed, and I think the whole point of doing this operation in the older person is to get them to weight bear. And if you've done an operation just through one approach, but you're still not going to let them weight bear, then I think that's a problem. So I think doing an anterior approach to gain stability of that column and reduction of that column if it's required, and then doing a subsequent posterior approach and allowing them to weight bear after the operation is far more beneficial.
Yeah. Kelly, what is the role for percutaneous fixation in this age group?
So, I mean, I still think there's a big role. First thing I'll say about percutaneous surgery is that as a staged procedure, you know, it does prevent that medialization that you see in the non-surgically treated patients. And Paul had some great x-rays of patients that had significant late medialization. So it does prevent that. So I use a lot of percutaneous surgery in minimally displaced or undisplaced injuries in young people. And in older patients, I do it in patients that are lacking those hallmarks of early failure. So posterior column impaction, gull sign, medial dislocation, and other significant markers of poor outcome regardless of treatment. But ABCs, anterior column, posterior hemitransverse, in the 70-year-old population, still 60 to 70, still pretty routinely treating those percutaneously.
Yeah. Cement versus non-cement, Paul?
So again, evolution of practice. We've become pretty obsessed in the UK with it becomes quite controversial to not cement above the age of 70. So if we're talking on the femoral side, that's pretty much standard practice. And especially this patient group, when they're coming with an osteoporotic fracture, one has to think that cement is meant for osteoporotic patients. So my practice has moved from being somebody who actually didn't really cement ever to cementing more often than not, certainly in this patient group, pretty much always.
Mez, anything to add to that?
No, I think cementing the stem is routine for me in this cohort. But I think the cement-less cups and the revision type cups are fantastic to gain primary stability.
And are you buying Paul's point about there still being some benefit about going front and back, or are you tending to do things more and more with an Uber arthroplasty rather than going and fixing the front first?
Oh, no. As I said, so our younger patients, and I'm saying younger up to sort of 75 or so, that would qualify for a fix and replace, get a dual approach. Yeah, it's the ones who are over 75, 80, 85-year-olds who will get a single approach and probably a cone.
Yeah. Kelly, I'm not asking you this question because I think you're an expert in it, but we've got to ask someone this question. Is there any role for non-operative treatment? Who gets non-op in your experience?
Oh, patients that are unfit for surgery, I would say. Patients where even in a femoral neck fracture that there would be a question about their suitability for surgery. They get non-surgical treatment, and then the completely undisplaced in the elderly patients, like the over 75 patients. Yeah.
Last question. And I'll be interested to hear what you guys say about this, is about AceFit. So AceFit was the British, it was just a feasibility trial looking at non-op versus fix and replace versus ORIF. That was, they recruited, and that's now closed. And we're now looking at the second phase, which will be AceFit 2. And my question to each of you, or to whoever who wants to take it, is, what does that experiment look like? What should the trial look like to answer this question? Because I think it's a really tough trial to organize.
I think the difficulty with this type of study, where the two treatment arms are so difficult or so different, is you would inherently bias the study by the outcome measure you choose. So if you're making those that are treated with fix and replace weight bearing, and those in the other arms not immediate weight bearing, which is what they're planning in the Canadian study, then your outcome is about early, 6 week, 3 month, 6 month functional. It's going to be strongly biased weight. Those patients are going to be functioning better at that stage. Your outcome is biased at one, where you expect replace group, the potential issue being need of revision and other problems down the road, but your outcome measure misses.
I just lost Kelly. I'm not sure that's my internet or yours, but Mez, anything to add on what the experiment should look like?
Yeah, I think it's difficult, isn't it? I think equipoise is a real potential problem with this group of patients, because what we found is that we had very few patients who we as a group of surgeons, and there were 4 of us, that hand on our heart said that actually this patient would be happy to randomize to either of the 3 arms, so non-op, surgical fixation, or fixation and replacement. And so that is a difficulty, and I think that probably differs between units as well. And I think that's going to be, so there are going to be some units that recruit lots, and some that recruit very few. And I think that's because of equipoise and experience, but also fundamental thoughts on how they want to manage fractures. So I think it's going to be very difficult.
Yeah. I'm aware that we all need to wrap this up, but Paul, last word to you. What does the experiment look like in your eyes?
Well, I think it's so frustrating because it's so kind of incredibly important, and I think because we definitely need guidance. I think there's clarity in what we need to do in the extreme. So the moribund patient we don't operate on, the highly functioning individual, we need to pull out all the stops and restore anatomy. But there's a massive group in the middle. And that's where the recruitment arm is just going to really, really struggle. And I don't know the answer to it. I think 3 choices is probably too much. And I think it needs to be a straightforward fix versus fix and replace. In my personal opinion, I'm always very uncomfortable with the thought of conservative management in any patient group where I feel we've moved on so far from that. But even the treatment arms, how is that going to look in different centres? They're going to be so different, and you can't force that onto a centre because there's so much variation in experience, training, and so it's a really, really frustrating one because it's so important and very, very difficult to deliver on, I think. And if we don't get it quite right, people just won't recruit. So. And then it's a whole lot of energy and effort, and we're no further forward.
Yeah. Kelly, you got cut off, so I'll give the last word to you. Anything to add to that?
So I would agree with that the non-op study or non-op arm of that trial is going to really impede recruitment. I think that would be the case here too. The Canadian study looks at ORIF versus fix and replace, but still, I think there's going to be issues with bias introduced with the outcome measure. So I think the study will go forward. I think there's a lot of appetite for it. It's not going to answer every question related to this, including what the long-term impacts of fix and replace are as far as cost to the system and reoperation and so on. But will be better than the information we have now for sure.